Hello, I'm your host, Peggy van der Plash, and today we're diving into the future of longevity, regenerative medicine, and the science of aging with an incredible guest from Europe as well, actually, Marco Quarta, who is the CEO of Rubedo Life Science. How are you, Marco?
I'm doing great. Thank you, Peggy. The pleasure to be here. And just to clarify, I'm not the CEO of Rubedo Life Sciences anymore because I hired a new rock star CEO recently.
Ah, congrats!
Thank you. We are now in the clinic. So Frederick Bedingfield joined, and I can tell more about this to drive the company through the clinic. So I'm still in the company, but I shifted to the chief scientific officer role.
Oh, that is fabulous. I always admire when people are able to understand, you know what, I will be bringing more value here and someone else going to bring more value there. I used to be a venture capitalist and I can tell you, I wished more CEOs would have done that. So congratulations to you.
Thank you. No, that's always been my plan when I started the company, knowing that you can't be a CEO for the entire life cycle. And as things change and grow, then, like you said, where you can add the most value and where is your sweet spot. And
Yeah.
Frederick, actually, we're partnering in crimes, which is an amazing partnership. We're really getting along and working great together. But he has done this multiple times, and he was CMO at Allergan. Is a MD, PhD turned executive. He launched products like Botox, right? Is
Oh,
some of
yeah.
MBM, for example. Since our lead program is in dermatology, but we don't want to be a dermatology company, he worked across many therapeutic areas, did successful IPOs, successful exits for $2+ billion in one of these companies, and then eventually was a venture capital himself at Apollo Health Venture, working on aging and longevity
Hmm.
therapeutic, age-related diseases. So it was a perfect match. And yeah, we just
So
took off immediately.
he
And I thought that
decided
he
to
was,
come back to the entrepreneurial lifestyle, which is a very
yes,
different lifestyle than a VC
very different,
lifestyle.
very different. He was not planning to do it, but he said, I cannot say, it's impossible to say no to this opportunity. So he came back.
So is he based as well in San Francisco?
Yes, he's in
Yeah.
the area as
That is
well.
the beauty of the Bay Area. You know, you throw a stone and you have someone who's incredibly competent and who's totally overlapping with what you're doing. You know, the depth of talent is so deep. You know, like it's incredible. So yeah, because I mentioned you are Italian, but you are in San Francisco. So let me introduce Rubedo, and then we'll go in questions, obviously. So the company really is at the forefront of targeting cellular aging with cutting edge therapeutics. And it's really the goal is really to eliminate senescent cells, so the so-called like zombie cells that drive age-related diseases. So many people are excited about that, including me. So you have a background in biotech, regenerative medicine, longevity science, and you're really leading the charge, I would say, in the way we approach aging and health span expansion, not just lifespan, but really health span. So I would love to start with your journey. So what inspired you to tackle aging at a cellular level and what makes Rubido approach unique?
Hmm. So that's a good question. I actually started really early because I was 5 years old when I decided that I wanted to cure aging in a naive way. But and we can add a story there. But anyway, that day already knew I wanted to be a scientist because I have several scientists in the family and physicians. But that day I decided, oh, that's what I want really to understand. And can we change the way we age? And yeah, in a very different way that I think this now, and less naively. After many decades, I'm still working on it, but that was really my initial inspiration. But that continued. I put together my first lab that year. So at the age of 6, I was in my little lab doing experiments. I had a real microscope, a real chemistry tools and things like that. help by my family, obviously. They said, "Well, good luck with that, but go
Go
try."
ahead. Yeah.
And and I was serious because I was not just playing; I was still doing it. But so those are studies that I've done. I was always been aligned with this idea in mind. So when
Mm-hmm.
I started back in Italy as a student, started to work in one of the lab under the patronage of a Nobel laureate, is Rita Levi-Montalcini. She won the Nobel Prize for discovering the nerve growth factor, NGF.
Okay.
So we're studying brain aging and brain regeneration and also things like chronic pain. And that I continued to my PhD in neuroscience and aging and bioengineering. And then I come at Stanford, where I continue working initially, with a postdoc in a lab of Tom Rando, as a person who's one of the leaders in the space of regenerative medicine, aging, that discovered this concept of the parabiosis, there are something in the young blood that makes older organisms, mice in that case, younger
Mm-hmm.
biologically, from improving their stem cell activities and function. And then I continued at Stanford for many years with my own group, studying aging and regeneration and stem cell. And in this journey, like trying to translate this into application. So I've been starting companies since I was a PhD student. First was in Italy, then more over my career, and from Stanford, Rubedo is my last, but I did others like Turn Bio, which is another company, the longevity therapeutic company that is focused on epigenetic reprogramming using RNase-based therapies and different modality. But I saw this very synergistic with Rubedo, right? Rubedo wants to remove the bad cells of aging,
Mm-hmm.
so the
Mm-hmm.
bad apples, to make the good apples rottening and become bad as well. Turn wants to remove, or to prevent the good apples that are becoming old, reversing the biological clock and to restore their function
Mm.
that has lost with aging to improve regenerative processes. And again, for different therapeutic modalities. But
Mm.
my vision and aspiration is that companies like that, the therapeutics like that, out of those companies can be synergistic in the
Yeah.
future,
Mm-hmm.
or a truly regenerative or rejuvenative in a way applications. But now the focus is really on specific indications, like chronic diseases of aging, where you can show in a relatively short time with defined endpoints efficacy and safety. And then you expand from there into larger and different therapeutic areas. And eventually, one day, it can be a preventative medicine to
Mm.
treat diseases decades before the actual
Mm.
onset, before they actually developed into diseases. So, like we already do this with diabetes, if you think about it. Like you can now do the blood test and see that you might be pre-diabetic, and then you can start to treat yourself 10 years before you
Yeah.
might become diabetic,
Mm-hmm.
even
Mm-hmm.
reverse this process and
Yeah. Mm-hmm.
return into a normal range. We can I envision this to be the same in a non-distant future. You can do a test and say, hey, your senescent markers of the liver are going up. If you
Mm.
don't take these therapies now, in 10, 20 years, you might develop chronic liver diseases.
Mm. Very interesting. So, one of the question I had for you is that we we tend to look at aging as something that is inevitable, and the way you framed it seems like actually we're going to be able to make it less inevitable than what we think it is. So, um, what is the science really behind your approach, and how does it differ from other longevity strategies that are out there?
Yeah. So maybe I want first to say that aging is inevitable. I mean, maybe from a conceptual thermodynamic standpoint, it could be thinkable, right? And some people say, well, thermodynamics shows that we actually, keep building entropy, and that can lead to inevitable decay. But actually, thermodynamics works for a closed system, a cellular environment is actually an open thermodynamic system where energy and matter goes in and out. So theoretically, you can maintain this state of information indefinitely, but there is no proof, and there is currently no proof on any organism, any as simple as good, that we can have something living indefinitely. So that's really not the focus of this field. It's not really extending lifespan, but like you also mentioned, it's really extending health span. So making sure that you can age chronologically
Yeah.
by maintaining, or making sure that you're aging biologically in the best possible way, so you retain your quality of life,
Yeah.
your health, your independence. That's the goal of longevity therapeutics now, and probably for a long time, because that's what we know we could do. Meaning, you can be 20 years old and be biologically aged. So
Yes,
it's really
absolutely. Yeah.
biological aging, right? We saw with COVID, or cancer survivors, there were chemotherapy,
Yeah.
radiotherapy.
Yeah.
Standard of care cancer makes you aging faster
Yeah.
because by trying to kill cancer cells, damage healthy cells, they
Yeah.
become senescent,
Yeah.
they are chronic inflamed, and even pediatric cancer survivors with children with leukemia that are treated and survive, but then in their 30s, they develop age-related diseases.
Interesting.
Or, COVID-19, SARS-CoV-2 is a virus that actually drives senescence in lung epithelial cells in other tissues. So severe cases we see in the clinic. We have a program in respiratory, in lung, interstitial lung diseases. When we see people in their 40s, 50s that need a lung transplantation with lungs that look like a 70-year-old person with idiopathic pulmonary fibrosis. So aging is a very plastic phenomenon, but you can do the opposite too, right? You can be 90 and be
Yes.
biologically younger and healthy and be independent. Now, how do I approach this at Rubedo? So to your question, so we are currently focused on this fundamental problem in aging biology, which is cellular senescence, which, for people don't know what it is, cellular senescence is really the result of stress and damage to healthy cells, or any cells in your body can potentially become senescent in response to these stressors. For example, we all know about a cancer, right? There are mutations. Mutations can lead to, a cell losing control and proliferating without, let's say, without being controlled by the body and over proliferate and create tumors and potentially maybe metastatic. Now, there is a mechanism in the body that can block cells that receive mutations to become cancer, which is cellular senescence. So a cell can stop dividing as a protective mechanism. Or there is a virus and the cell can stop because to prevent this to do
Yeah.
additional damage, mitochondrial damage, epigenetic damage or stress, shortening telomeres, etc., oxidative stress. So there are many ways that cells respond by becoming senescent. So it doesn't divide anymore. But then it changes. And to tell the body, I'm here, there is something wrong, get rid of me, cells release factors. It's like a signal to the immune cells to say, find me and get rid of me. And this does that by secreting lots of factors. This is a good thing. But in science, we say this is a pleiotropic biology, because it can be a double-edged sword. So while this is good to prevent damage, but with age and disease, those senescent cells actually can escape now the immune surveillance. So immune cells don't find them anymore, or they're not as good as removing them. So those senescent cells start to build up in the tissue, but they don't die. They stay there, and they keep releasing those factors, which are toxin for the body somehow. So they're causing the immune cells to almost lose control, to become, we say, maladaptive, to become aberrant. And so together now they start to create a chronic inflammation that keeps growing, that promotes fibrosis, that promotes more cancer,
Yeah.
So it's kind of paradox effect because
Yeah.
initially blocks
Yeah.
cancer,
Yeah.
but now it promotes it.
Yeah.
And so they're behind many degenerative phenomenon that we see in the brain, like Alzheimer's, Parkinson, metabolic disorders like diabetes,
Mm.
obesity, fibrosis in tissues like lung, liver, kidney, sarcopenia, etc., etc. So it's one of the causes of aging,
Hmm.
and is caused by aging and is cause aging. So it's a
Yeah.
loop.
Uh,
Now, the solution to that is get rid of those zombie cells, like you call them,
mhm, mhm.
um, pharmacologically. So if you can do what the body fails to do, um, what we and others showed over the past 15 years in animals, right? You see a dramatic effect. So you don't only slow down this degenerative process, you can stop and, in certain cases, reverse it.
Reverse. Hmm.
So
Wow.
you see old mice that, for example, regrow hair, regrow muscle, they
Mm.
regain cognitive functions, they have
Mm.
less tumors, they live longer, they live healthier. Now, the problem, the complication is that senescent cells, so those zombie cells, are not all equal. They're not all the same. They're
Mhm,
very
mhm,
different. There are different flavors and types. Some are even good. You know, we use senescent cells during embryogenesis, so to remodel tissues. We can use some to help wound healing.
mhm.
Um, and it's good when they appear and then they disappear. It starts to be bad when they don't go away
Gotcha.
because they become chronic. So there is a timing issue and there is a type issue.
Mhm, mhm.
It's like cancer, right? You cannot treat all cancer with the same therapy.
Yeah. Yeah.
We 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 learned that over the past 50 years of oncology. In the early days, people thought it was possible in the 60s, 70s, and a little bit how the field of the xenotherapeutic started to make senolytics, or drugs that can remove senescent cells, are called senolytics. Started thinking, great, we have examples of drugs that can maybe be repurposed from the cancer space or from a natural world that in a petri dish, like in vitro,
Mhm.
seems to be killing senescent cells. Therefore, we should be able to do this also therapeutically. Maybe in animals showed some promising example, but then in humans it's not that simple to translate it because they are not all the same. So you might go after the wrong target or the
Yeah.
wrong
Mhm, mhm.
cell. So that's what we do at Rubedo, right? We build a way to study and find and discover the different type of senescent cells.
Okay.
And we use this we build a platform to do that. Combines different type of, let's say, algorithms like artificial intelligence, like deep neural networks, machine learning, and other strategies to help solving this complexity, analyzing data cellular data
Mhm,
at single
mhm.
cell level. So there are a number of technologies like single cell RNA sequencing, spatial multiomics, transcriptomics, proteomics, other things like that that are very powerful, meaning that you can take a biopsy from a patient, you can, digest the tissue so you have a suspension of every single cell that was there, and then you can sequence and look inside every single cell and
Mhm,
look for every single gene that is turned
mhm,
on and
mhm.
off, every single protein or protein, many of them, and things like that. But then you have such a complexity that what do you do with that? So that's why we build a platform that can generate this data, analyze this data, and find the right cells in the right place and the right vulnerability.
Uh-huh.
So now we know what type of drug we can design and develop, not repurpose. So we make novel therapeutics. So we have to find a way to target the right cells in the right
Yeah.
way to treat the right tissue or the
Mhm.
right conditions. And
So
that's what we really do.
are you planning to also do the drug discovery to find this therapy, or are you staying at the platform level and then other companies will use your platform to develop each specific therapy for different type of cells and different types of
Mhm.
use case?
No, we do this everything. So we
Okay.
arched from the platform to a therapeutic pipeline already,
Okay.
and we have many programs, and we are in the clinic now. We first program. We are a clinical stage company now,
Hmm.
and the first program moved into the clinic now as we speak, and we are starting with skin. So we
Okay.
decided to start with skin aging and chronic inflammatory skin conditions, like atopic dermatitis, psoriasis,
Psoriasis.
vitiligo,
Yeah.
actinic keratosis. There are a number of others that are. The common denominator is that those conditions have a chronic inflammatory process.
Uh-huh.
They don't resolve. Many have unmet medical need, big markets, big
Yeah.
patient populations. And yet, for us, it's just a starting point. We don't want to be a dermatology company.
Yeah.
I hire Frederick, the new CEO, who's a key opinion leader as a dermatologist. He launched many programs in the space,
Uh-huh.
but he also worked in other areas. And he joined not to make a dermatology
Yeah, yeah,
company, but
yeah,
this is
yeah.
only the tip of the spear. But it's an easier way to start, right?
Hmm.
Like skin, you can see it, you can sample it,
Ah, okay.
um, and it's unique because this clinical trial that we're doing is not on healthy volunteers, but as the design is for patients. So it's a phase one
Okay.
where you typically test safety, but we are enrolling patients with different skin conditions. It's called a basket trial. So we
Mm-hmm.
can test multiple diseases at
Gotcha.
the same time. We can test not the skin lesion, so therapeutic effect, but also the non-area,
Yeah.
the non-lesional
Uh-huh,
area,
uh-huh, uh-huh.
where we are going to look for skin aging, like epigenetic clock and
Yeah.
markers, biomarkers of aging, while in the lesions, we're going to look for the targets and the biomarkers of the disease.
Mm,
So we're going to be a rich package to test these hypotheses, starting with the skin, but then going systemically into other
yeah.
immune and inflammatory, so the I&I, so-called I&I therapeutic area, with this target. And the target we disclosed recently, it came out of the platform unbiasedly. We didn't know what we were looking. So we found the cell, then we found the target, and then we developed new molecules. It's completely new. It's the first in class. It's the first time that this target goes into the clinic,
Hmm.
although there are many other pharma companies that are working this target, AbbVie, Takeda, GSK, and others. And it's GPX4. And
Okay.
GPX4 is an important element of a pathway called ferroptosis, so controls a form of cell death that is different than the typical one that is called apoptosis, just a way how cells control how to die.
Mm-hmm.
And we found that senescent cells have a natural sensitivity to respond into the modulation of this target. So we've developed a molecule which is a modulator that can trigger and push certain, not all,
Mm-hmm.
certain senescent
Mm-hmm.
cells to die, but
Okay.
leave the other cells
Okay.
unaffected.
So some zombie, it's a zombie apocalypse, they disappear, and some actually who are still doing, as you were saying, their work, helping with healing and things like that. These ones you're keeping. And so, like based on what you're explaining, my understanding is that you've been using tremendously tools such as AI and predictive analysis and all of that. So does it mean that your findings would not have been possible even 5, 10 years earlier because there was not the technology for that?
Absolutely. Yeah, it was not
Hmm.
possible 10 years ago for sure. 5 years ago, it started to be, but it didn't exist anything like that. So we had to build the tools that
Hmm.
didn't exist. That's why, as a biotech company, we have also a CTO.
Yeah.
So we are a
Hmm.
mix of biotech and tech bio,
Yeah.
if you want.
Hmm.
A CTO that actually comes from Silicon Valley big tech. He
Uh-huh.
was one of the elite software engineer at Facebook and other
Yeah.
tech companies. that really came with the unique capacity to build tools and infrastructure. It's not apply bioinformatic or things that were existing, but we had to invent from scratch
Yeah.
solutions
Hmm.
like we do. We build from scratch new molecules. We don't repurpose existing drugs. We
Yeah.
make new drugs.
Yeah.
We also make new softwares, new tools that can help,
Hmm.
this and drive the discovery process.
Hmm. I have a question. You were obviously mentioning the fact that you're in a clinical stage, phase one. I know that the clinical, process, phase one, phase two, can be quite long. Do you have an idea of when you think you're going to be able to go to market?
But we chose skin because it can be a fast track, it
Hmm.
can be accelerated. So, and because, this basket trial that we design should a little bit accelerate the process, although you still need to do a phase two,
Yep.
where we will select the best indication based on this phase one, and then move forward. But it could be in not many years from now
Mm.
for this first indication. So
Yeah.
shorter than the typical path, like 7, 10 years. We hope that that could be in, maybe as fast as it can go. Could be 4 or 5 years.
For 5 years. Okay.
Um,
Oh.
but it's also not just the timing, but it's also the de-risking
Hmm.
value of the approach.
Yeah.
So there are lots of unknown. A clinical trial is an experiment on
Yeah.
the best species that you could use to test your drug, which are humans.
Yeah.
And as all experiments come with things that you don't know,
Hmm.
otherwise you wouldn't run the experiment.
Yeah.
And sometimes it fails, not because the drug doesn't work, but because maybe you couldn't prove in the proper
Hmm.
way with the
Hmm.
right number of statistics. Maybe
Yeah.
there is too much noise, um, or human error. Sometimes your patients are wrong or they don't stay on your trial,
Yes. Hmm. Hmm.
and there are just there are so many complications. So we just try to build into our whole discovery process and development ways to de-risk this and maximize chances to succeed,
Mm.
not just to move faster, but also to do it as accurately as possible. And so there is skin, but for skin, because there is therapeutic value, but as I said, we're looking also at AG skin. There is also an aesthetic cosmetic
Mhm,
opportunity,
mhm, mhm,
which it's a separate vertical that we are pursuing with partners. And last year we announced a strategic partnership with Bayersdorf.
mhm.
Bayersdorf is the parent company behind products like Nivea,
Nivea. Mhm,
Eucerin, Coppertone, La Prairie, and this is like multi-year, large pharma-like deal that we signed to develop together, really the first real
mhm.
anti-aging cream for skincare,
Yeah,
not just based on marketing, but based on actual
yeah,
potential real biology that can
yeah.
not make the skin look younger, but actually be younger for a
And
longer
that you
time.
can see with your clinical trial because you're doing lesion and you're doing non-lesion. So you're doing, as you say, this
Exactly.
basket approach. So that's great. And am I correct to think that when you're coming with a next wave of clinical trial with your next thing is going to go faster because you would have done already this, or do you think every time it's a bit like starting from the
We're trying to do like the same target, right? This GPX4.
Mhm.
We will follow with the systemic treatments for other indications right after. So to piggyback on this initial targeting skin. Um, but you still need to follow regulatory process. But the way we're thinking is like trying to have all align and that one phase leads to the next without gap in between.
Okay, okay, okay.
So that can really shorten the
Yeah.
timing for potential approval, and stay on track.
Hmm. Hmm.
I have to say the current process for a drug approval has pretty solid. I mean, it's required. You need to do this to prove that actually a drug is safe,
Yeah,
number
yeah.
one, and it works effectively, and it is required this amount of time.
Hmm.
Sometimes you can't really
Yeah, shorten it.
avoid it.
Hmm.
Yeah.
Hmm. Well,
Yeah,
at least you would have the experience, and to your point, is this dead time in between that maybe you can shorten and go
yeah.
faster. I have one last
And
qu Oh, sorry, go ahead,
just the
Marco.
wrong thing is, and the data, and all the data that we collect from a clinical trial, we also are leveraging ways to do data mining and algorithms
Hmm.
to, again, accelerate or expand the view to design the next step, the
Yeah,
next trial.
yeah.
But to your point, to help the other work, because we have other targets. We in the pipeline, we have other programs. As I said, one for respiratory, so lung diseases like lung fibrosis or COPD, pulmonary hypertension. We're working on chronic pain, for example. Now
Yeah.
we have a paper accepted, is coming out soon on a top tier journal with collaborators from Stanford, with Professor Taufik, on chronic pain and the role of cellular senescence and how
Mhm.
removing that can really prevent this development of allodynia and neuropathic pain. And that's another very exciting
Yeah.
therapeutic areas. And so, of course, why with the success of a first program, like starting with the skin, will help to move
Yeah.
faster on the other
Yeah,
ones.
yeah,
Yeah.
yeah, yeah, yeah. I can see that. And one last question I have for you is regarding public policy and regulations, because it can kind of make or break the speed of innovation in biotech. So what do you see from your perspective could be a plus or a minus in terms of public policy to move forward better
Mhm.
and faster with your research?
Yeah. So right now, the field has constraints, and the limitations are, well, number one, like aging is not a clinical indication approved, but even if it
Hmm.
was considered, let's say, a syndrome, like could be sarcopenia,
Yeah.
um, running a trial would be extremely challenging. Like the only way now would be what? To take elderly, put them on a trial for 10, 20 years,
Yeah.
maybe, considering the variability of such a study. You probably need a large amount of people,
Yeah.
hundreds, maybe thousand. It's hard to measure beyond like survival, where it is that you can
Yeah.
follow them and see when they die or
Yeah.
how many comorbidities they develop. And it's extremely challenging, expensive. In other words,
Mhm.
is not sustainable.
Yeah.
And it's primed to fail because the human error, you can imagine putting on trial for 10 years someone who's 70 or 80 years old. What can go wrong?
Yeah.
People will forget doing the
Yeah. Yeah.
treatments every single day. I mean, it's just impossible. And so now the field needs to choose age-related diseases as a first entry point and start
Hmm.
to
Hmm.
move from there.
Hmm.
Like we are seeing now with Ozempic, the
Yeah.
GLP-1 started with diabetes, moving to obesity and
Yeah.
expanding other therapeutic areas. But the field, and from a terms of policy regulatory standpoint, if there is focus and incentives to validate, for example, predictive biomarkers, validate them clinically. Something that, like I mentioned earlier, you can measure now that can tell you the trajectory of your biological aging process in 10 or 20 years from now.
Yeah.
This now has been done in other diseases, like in diabetes. There are biomarkers that tells you if you start to be in the range of pre-diabetes,
Hmm.
etc. Once we have this framework of biomarkers that validate the prediction power and potential outcome, there are tools now like epigenetic clocks, but they're not validated. They're not telling us the prediction power for future. Now it changes track with preventing development or reversing it even. We don't know that yet. But if there is this framework developed, now we can think about trials that are like a year long.
Hmm. Hmm.
You can put a small number of people on this trial, test these biomarkers, and start to anticipate potential changes that might result from that. And I have to say the agencies are working on that. There is recently an ARPA-H here in the United States grant or program that wants to support this, like establishing a framework to develop biomarkers and clinical trial design, a way to test therapeutics for longevity or testing resilience
Hmm.
specifically, and how that can be improved in a very manageable time frame instead of waiting 10, 20 years. And this is the kind of effort that is really important to change the field.
Hmm. I thank you so much, Marco. We're already, unfortunately, also almost out of time. I think we could have spent the entire afternoon. It's so fascinating, and you're able to break it down, even for someone like me who doesn't know anything, where it makes a lot of sense. So thank you for the vulgarization. Really appreciate it. Do you have any parting thoughts or any parting words you want to share with the audience?
Well, I first I want to thank you because I think it's important to just have advocacy and communication, and everybody can really make a contribution to that. This is, longevity therapeutic is not a vanity. It's a socio-economical crisis up and coming because with a growing aging population globally, the problem is not that people living longer. The problem is that people living longer with sick
Sick.
with
Yeah.
diseases, and so the social and economical and emotional cost from single to family to societies at some point will become, it's already becoming unsustainable. And
Yes.
so this is a solution to a global problem that is not only solvable by developing those therapeutics, but by developing the culture around that,
Hmm.
changing in behaviors. People need to understand that needs to change certain lifestyles,
Yeah.
education, training for physicians, et cetera, to enable this ecosystem that one day can really change how we think about medicine.
Absolutely. Well, thank you so much, Marco. Really appreciate you taking the time. Good luck with the trial. We have a few
Thank you.
years ahead of us, so we might touch base between that, but really good luck. I think that's very promising and very interesting how you're doing the platform, the therapeutic, and all this therapeutic. I mean, that's really impressive. So thank you so much for being here today.
Thank you, Peggy. It was such a pleasure, and thank you for the opportunity to share this with the community. And I'm looking forward to keep following your work.
Thank you so much. Bye, Marco.
Bye bye.